I want to thank you for giving me the opportunity to make this presentation to all of you this afternoon. Is the volume good? Are we need it a little louder? How's that? Good. Okay. So during the 1970s and 80s, I was involved in looking at the primary health care model and using the idea from that of health worker and community collaboration to address maternal and child health in low-income communities in Chicago. And in the 1980s, at this same time, the HIV epidemic was spiraling out of control, and particularly in Africa. And Sheila Clow, who was completing her doctoral study at UIC at the time, and I talked about how this model might be a way to build a program of effective and affordable HIV prevention. So we applied for one of the very first calls for international research on behavioral models for HIV prevention. This research also launched Dr. Clow in her amazing career as the first female Minister of Health in Malawi and the first nurse. And then now she is director for the Eastern and Southern region of UNAIDS. So a quick geography note. There's Botswana, where I started out, and then Malawi, where I took the program next. And, as was alluded to in the introduction, we developed a rather complicated conceptual model for HIV prevention. The first component used the primary health care model from WHO for service delivery. We used the basic idea that was developed by Bev McElmurray, who many of you may have known and remember well, taking health workers and trained community members to together address their community health problems. And this combines the community members' understanding of the local context and culture, the health workers' knowledge specific to health, and the university's multidisciplinary vision and research techniques. But then we needed to guide the actual peer group intervention, and we used Bandura's social cognitive learning theory, which uses skill building and rehearsal to help people feel confident that they are able to make changes in their lives. And the final component that we used is contextual tailoring, focusing primarily on gender issues and the culturally sensitive topic of sexuality, which is not to be discussed in public at all, and certainly not between partners or between parents and children. We also emphasize using local leaders and local resources. So in Botswana, we created peer groups for women who worked in banks and the laundry workers and cleaners at the University of Botswana, a very convenient setting. And then volunteers from each of those groups, we trained to be peer group leaders, and then they actually offered the intervention for the women. Using a classical intervention control group with pre-test and post-test model, we found the intervention was highly successful, leading to increases in knowledge, self-efficacy, personal safer sex, positive attitudes, and community prevention activities. And you can see here one of the results using safer sex, which we defined as either using condoms all the time or not having any sex at all. And both groups had some increase due to the general expansion of educational programs for the general public. But the intervention had a significantly higher increase than the control. At the end of this program, the Botswana Council of Women, who had been our partners in putting this together, decided that they would take over the program and see that it continued. So I said to myself, well, I better move on. I need a country that needs a little bit more help. And my former doctoral student, Chrissy Kaponda, had just returned to Malawi, which happens to be the 5th poorest country in the world. And HIV was rapidly increasing, but there were no HIV prevention efforts whatsoever countrywide. So I obtained a small Fulbright to conduct some preliminary work there. And that very small grant eventually led to 3 R01s. The program there was modified to include men. We called it Mazaki di Mazaki, which means friend to friend. We conducted it with primary school teachers in training, and they were very enthusiastic about the program, and they had improved knowledge, attitudes, and intentions to change behavior. The Ministry of Education was impressed, and they decided to add it to their curriculum for new teachers in training. So then, emboldened by our success, we applied for funding and from NACNR to conduct this same program in a rural area. And this gives you a sense of what the rural area looks like. The top left is the district hospital, which is considered a secondary level facility. Below there's a community center with the health workers relaxing on the steps. On the bottom right is one of the villages, and above that, one of our team interviewing a woman in the typical for rural areas research setting. And this gives you some idea what the intervention looked like. Again, we got volunteers, and this time we trained health worker volunteers. The upper left shows part of their training. And then during this training, we realized that the health workers also really needed HIV prevention. So we expanded the scope of our program. Then those health workers offered peer groups in the community. And of course, after the first few groups, some of the community members also became peer group leaders. They offered the program to over 2,000 adults and over 1,000 youth. You can see a role play in one of the youth groups there. And then at the end, everyone got certificates. So this program improved knowledge for all 3 groups, the health workers, the adults, and the youth, as well as self-efficacy for safer sex. And it also changed behaviors. There was more HIV testing for all 3 groups, more safer sex communication with partners, lower overall risky sex for health workers and adults. That included things like paying money for sex and drinking before having sex and so on. And greater condom use for adults and youth, but not health workers, and increased involvement in community HIV prevention for all. This shows one of the results, condom use. You can see the health workers didn't do so well. They actually had lower condom use than the control group. But this needs to be balanced by the fact that they were also reducing their other risky behaviors. The adults increased considerably, and the youth even more. So we also looked at HIV testing, and in this case, all 3 groups increased significantly, although the rates are still really low. And this data is from around 2001, 2004. And since then, testing has really taken off in Malawi, so don't think these would be the rates today. We were particularly excited by the health worker changes. They engaged in more teaching. They had fewer needle stick injuries. They had more glove wearing and more hand washing. Notice hand washing is lower than glove wearing. But, you know, you can't do everything. So this intervention really showed that increased HIV prevention was possible for rural and urban health workers, adults, and youth. This was a time when many people were extremely dubious that behavioral intervention could really change sexual behaviors. And our process evaluation showed that volunteers can deliver this program effectively with fidelity. And long-term follow-up found that the peer leaders remained active in their community, helping their neighbors, etc. However, the formal peer group program was not sustained. Somewhat concurrently with this, we had the opportunity to get funding to do this same project in the urban hospital in the capital city. And here you see a picture which doesn't look all that different from the rural hospital, but does have the sterilizer and so on. Using a pre-post design, we had very similar results to rural health workers, including more positive work-related behaviors. But they did not change their sexual behaviors. So we then thought we should take this model to the growing concern over the reproductive health for young women. We integrated the overall sexual health into the Mizaki program. Young women, as they grow up in Malawi, have a very serious dilemma because they're at an age where it's natural and appropriate that they be forming romantic relationships, probably having their first sexual encounter. And all of this exposes them to the risk of HIV, STIs, and early pregnancy. So we randomized at the community level in this study in 16 different villages and recruited young women ages 15 to 20. We integrated overall sexual health, including contraception and preconception health, into HIV prevention. However, in this study, we had 4 outcomes that improved at 6 months postpartum, but not at 12 months. And they were consistent condom use at last sex, birth control use, and avoidance of pregnancy in the last 6 months. We had 2 outcomes where there was no effect whatsoever. One was abstaining, which also was not affected in the previous rural study with the general population, and having a recent HIV test, which probably reflects the growing availability of HIV test opportunities. And this just gives you an idea of what's going on with these results that are there at 6 months but then disappear. This is pregnancy. You can see they're pretty equivalent at the baseline. And then 6 months after they complete the intervention group has many fewer pregnancies than the other group. But at 12 months, they've kind of evened out. Now, delaying pregnancy in itself for 6 months is probably a good thing for young women of these ages. But in terms of implications for future research, the young women reported quite frequently that their partners and their parents did not really support the behavior changes that the intervention was modeling for them. And of course, we need to remember that young women ages 15 to 20, and I'm sure some of you have had adolescent daughters, are naturally going to move to marriage and having children as they grow older. But because of the long-term lack of impact, this program cannot be really recommended for replication. Some possible strategies to increase effectiveness might be engaging partners, parents, and the community, as we did in the first intervention, which had more consistent results. Another possibility would be to offer more ongoing booster sessions that would keep the young women engaged and thinking about these issues as their life circumstances changed. So that brings us to our current research, which is looking at two really major global health research priorities. The first, of course, is how do we scale up all of these effective interventions that have been paid for by our research dollars, but then kind of languish. The average of 17 years from discovery to implementation and practice remains as true today as it did when it was announced many years ago. And the second global priority is the need for more effective HIV prevention in order to reduce new infections. And that means both getting people in for testing and then getting those people in for treatment. But it also means paying attention. In Malawi, approximately 85 to 90% of the population is HIV-free. And it's important that those people also change their behaviors so that they don't become HIV infected in the first place, which is far more cost effective than discovering that they're positive and treating them. For this project, we turned to Palumbi district in the southern region of Malawi, which actually has twice the rate of the rest of the country. And just before funding, Dr. Kaponda was offered the very prestigious position of High Commissioner from Malawi to South Africa. And she went with that and had to withdraw from the study. Our loss was her country's gain. Fortunately, Dr. Jerry, another former PhD student of mine, had gone back a couple of years before, and she was up for the challenge of being the co-PI on this project. So we wanted to create a strong local partnership that would help the program to continue. So the communities provide the volunteers and the organizational capacity. The health system provides health workers, and they are the trainers for this program. The political district authorities provide dissemination of the project throughout the district, and they also have promised that if this is successful, they will steer some of their HIV funds to these communities. And the traditional authority system, which is very strong in Malawi, really is the group that mobilizes the communities. And of course, we provide the money and the technical things. So we also needed an implementation model, and we turned to a model that had been used in South Africa for an in-hospital intervention with very great success. And we simplified it further to have just 3 steps. The first is to prepare, the second is to roll out, and the third is to sustain. And this is a cyclical process because in order to sustain, you also have to go back and bring new people in and train them and then so on. And for each of the steps, we worked with the community members and developed measures of what things should be happening, which they can use to guide their implementation. And it also becomes one of our major outcomes for quantitative evaluation of the amount of implementation that's happened. It's a staggered design with 3 sites, each one doing the same things over time. And we used a hybrid mixed design. First, we wanted to know if the communities could do it, which is measured by the benchmarks. And then we wanted to compare the patterns of implementation over time and across sites using qualitative and observation as well as benchmarks. We also are looking at whether the program is effective, which is the part that would look familiar to all researchers because it's a survey of outcome data, individual outcomes. And then we will put all of this together to determine the overall effectiveness. So getting started required many meetings. Here you see us meeting with the Health and Environment Committee of the District Council. We're training some of the group village leaders and presenting them with their certificates. This is actually the district commissioner who is like the governor, who thought enough of this program to come for the certificate presentations. Then we trained, there we go. We got health workers to volunteer as trainers, and we gave them the training, and then they did a pilot. Then the first site, we were now ready to go to the community level. The first site established a coordinating committee. We trained them in both the model, here you see a role play, here you see condom practice, and in the implementation model, you can see they've written out some of the steps that have to happen, partly in English, partly in Chichewa. And then the community peer leaders were nominated by the committee, and they were trained, and then they conducted the intervention with 190 adults and 190 youth. And then the coordinating committee made a progress report to the community leaders. This is that meeting. And this is the numbers they've trained, adults, youth, and total. This is the total population and the percent they've trained, which is still pretty low. So they know they have a lot of work to continue to do. Now, I think from this project we're learning that communities really understand the need for HIV prevention in their community. And they've been very frustrated by research that comes and goes, gets them all excited about something and then disappears. So they're extremely eager to take on this program. And the model is successful thus far. Next year, Community 1 begins sustaining and Community 2 begins preparing and rolling out. Our two big questions are, can Community 1 sustain their enthusiasm? And can Community 2 do the same good job? Now, we also use this same model in a few other places. We had a long relationship in Lithuania, and we went there and offered this as a one-day workshop to practicing nurses in communities and hospitals. And had good results and a warm reception, and it became a permanent offering in their required continuing education program. This also provided a global health experience for 3 doctoral and postdoctoral students at USC. Then we went to Chile, where we had a couple of PhD students from Chile who said, you know, we have exactly the same HIV prevention problems in our clinics. So we decided to take this there, and indeed we had very similar results. And 4 of our collaborators received PhDs at UIC, and 2 obtained Fogarty funding to carry on their work, taking the intervention to both women and men in the community. We also, we also did community education, the antenatal care project, which Rebecca talked about. This is the next step. We conducted a larger pilot in both Tanzania and Malawi. And here you can see the women doing their self-assessment. This is a brief consultation with the midwife. And then they sit together, guided by the midwife and her helper, and talk about interactive health learning. This makes possible one midwife and a helper to see 12 women in 120 minutes, which is 10 minutes per woman, which is actually within the length of time that is usual, which is 7 to 12 minutes per visit. So that this can be offered, giving each woman a 2-hour experience, which they love, without having to have a whole bunch of new health workers. And we're very excited about moving that forward. And of course, I also went back to my maternal child roots and joined forces with Rosemary Whitetrout, who's been sponsored by NIH quite a lot over the years, and integrated a nurse community worker team to teach mothers of preemies their infants' behavioral cues and how to read them, how to determine their states, and as well as giving their baby the multisensory intervention. You can see how happy both the mother and the baby are here. It's also important that community research mentors the next generation. So here is one of our junior faculty, Dr. Saria Lofton, who's hoping to do photo voice as part of our implementation project in Malawi. One of my former graduate students, who's now the director of maternal child health at the University of Indonesia, and a couple of people in the pipeline. This is Evanthea Arianes, who just got her master's, and this is Najan Robinson, who just graduated and is going into a nursing advanced practice degree at Rush in the fall. And this just shows the reds are where I've done things. The yellow stars are where my students have been, just to give some idea of the, a few dollars really do multiply over time. And I want to thank my funders and say goodbye from Palombe, Malawi. This is the view from our office and where we stay in Malawi. So thank you very much. Any questions?